course is approved for 6 hours of QME continuing education by the Division of Workers' Compensation. This is your author and narrator, Dr. Perry Carpenter. I hope you enjoy the program.
Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're in session number 5 of our new series entitled Permanent Impairments of the Tendinopathies. And we're now in section number 3 of this program, wherein we're actually discussing the permanent impairment ratings and the different options that you have for providing for permanent impairment for your examinee who has one or more of the common tendinopathies that we see in our examinees. And in our last session, we talked about the different options available to you for those examinees who have permanent impairment due to shoulder tendinopathies. In today's session, we're going to talk about permanent impairment options for lateral epicondylitis or elbow tendinopathy. And then in our remaining 2 sessions after today, we're going to talk about some lower extremity tendinopathies, namely patellar tendinopathy. And then in the foot, we're going to talk about both Achilles tendinopathy and then also plantar fasciitis, which is another form of tendinopathy. So I have a fascinating program for you today. And this is going to be some material that's going to be immediately useful to you in your workers' compensation qualified medical evaluator practice, because lateral epicondyle pain, lateral elbow pain, is a common occurrence in the industrial setting. So I'm sure you will be seeing this type of examinee in the very near future if you haven't already seen dozens or maybe even hundreds of them up to this point in your practice. So with no further ado, let's get started on today's session, which is permanent impairment due to lateral epicondylitis.
Okay, so let's begin with some facts about lateral epicondylitis. Now, in the general population, lateral epicondylitis affects 1 to 3% of adults each year. And in speaking with you out there, I wonder if any of you listening to this program have lateral epicondylitis. I know that I've had lateral epicondylitis, being both a chiropractor and a recreational weightlifter. It seems that lateral epicondylitis is something that I seem to chronically fall into and fall out of kind of cyclically throughout the year. And if you've read up on this condition in Chapter 16 of the AMA Guides, the AMA Guides describe lateral epicondylitis as a stubborn condition, quote unquote, a stubborn condition. And if you've ever had lateral epicondylitis, you will certainly agree with that description, that accurate description, because once this condition sets in, it becomes stubborn and recalcitrant to treatment because of the tissues involved. They are so difficult to rest, because every time you move your fingers, you are activating the muscles responsible for lateral epicondylitis. We'll go over those muscles here in just a moment. Now, lateral epicondylitis was first described in 1873 by German orthopedist Runge. Runge described it as writer's cramp. Of course, we didn't have tennis in 1873, so it seems that this condition was first described and first identified in writers, people who used pens for a protracted period of time. And Runge published an article entitled On the Causes and Treatment of Writer's Cramp, and he was describing pain in the lateral epicondyle. Well, the term writer's cramp fell out of use in 1873 when Major first identified this condition in tennis players. Of course, all tennis at the time was played on grass, and so Major described it as lawn tennis arm. Now, in this day and age, lateral epicondylitis has come to be associated with what's referred to colloquially as tennis elbow. So with regards to tennis players, 50% of recreational tennis players will experience symptoms of lateral epicondylitis, but tennis players make up only a small percentage, maybe 5 to 10% of the overall patient population with lateral epicondylitis. And in today's discussion, we're going to be talking about the percentage of population experiencing lateral epicondylitis as a result of repetitive, cumulative, and excessive workplace duties. So even though it's seen in high percentage of tennis players because of the nature of tennis and the grip and the racket and the strings and the impact of the ball, tennis players only make up a small portion of the overall patient population with lateral epicondylitis. Okay, so here are the muscles involved with lateral epicondylitis, and these are all located on the extensor surface of the forearm. So from inferior to superior, we have the extensor carpi ulnaris muscle, we have the extensor digitorum communis muscle, we have the extensor carpi radialis brevis muscle, and then on top, we have the extensor carpi radialis longus muscle. Now, all of these muscles combine to form the common extensor tendon right here in this region. And the common extensor tendon attaches either on the lateral epicondyle of the humerus here, or on this ridge above the condyle known as the supracondylar ridge. So the extensor carpi radialis longus attaches on the supracondylar ridge, and the other three muscles attach by way of a common extensor tendon onto the lateral epicondyle. Now, anatomically speaking, this region here is the belly of the muscle. This region in through here is the myotendinous junction. And then this region here where the tendon attaches to the bone and becomes continuous with the periosteum of the bone, this is known as the enthesis. So with lateral epicondylitis, we're going to see that the examinee can report pain in any of these zones. They can report pain in the proximal belly, in the proximal muscle bellies. They can report pain in the myotendinous junction. They can report pain anywhere within the distribution of the common extensor tendon. And then they can also report pain directly on the bone. This is referred to here as lateral epicondylitis, where the bone itself actually becomes inflamed and edematous and involved in the production of the painful symptoms. Now, most commonly, the pain is going to be the result of dysfunction and tendinopathy of the extensor carpi radialis brevis muscle. So most commonly, the point of greatest point tenderness, at least to palpation, would be right here in this region over the tendon of the extensor carpi radialis brevis. Now, we're going to go over each of these four muscles individually in just a moment, but it's important now to realize and recognize that each of these four muscles are two joint muscles, meaning that they cross two joints. So as we can see here on this diagram, all of these muscles attach on the humerus bone here, which is on the high side, the far side of the elbow joint. And then all of them continue down into the forearm, cross the wrist, and attach on some point across the wrist onto the hand. So these muscles act and operate at both the elbow joint and then also at the wrist joint. So these are two joint muscles that are affected by activity at each and at both the elbow and the wrist joint. And this is going to be important to know when it comes time to provide for permanent impairment for lateral epicondylitis. You're going to see that you have options related to impairments associated with loss of function of the elbow, but also you have available to you options related to loss of function of the wrist, because these are two joint muscles that affect both the function of the elbow and the wrist. Okay, so here is the extensor carpi radialis brevis. It has as its origin the lateral epicondyle of the humerus, where it attaches by way of a lengthy tendon, and then continues down the forearm, crosses the wrist joint here, and attaches on the base of the third metacarpal bone right here. So because of this anatomy, the extensor carpi radialis brevis functions to extend and weakly radially deviate the wrist. So you can think of your manual muscle testing to specifically isolate this muscle would involve resisted wrist extension and resisted radial deviation of the wrist. So note that this is a two-joint muscle, crosses both the elbow joint and crosses both the wrist joint, and is going to be affected by physical activities in the workplace that involve both repetitious movements at the elbow and repetitious movements at the wrist. Here's the extensor carpi ulnaris muscle, the most inferior of the muscle bellies on the extensor surface of the forearm. Has also its origin on the lateral epicondyle of the humerus, comes down along the distribution of the ulna bone by way of a long tendon here, and then crosses the wrist joint to attach on the base of the fifth metacarpal. So the extensor carpi radialis brevis attached over here on the base of the third metacarpal. Here we have the extensor carpi ulnaris attaching on the base of the fifth metacarpal. So because the fifth metacarpal here is lateral to the axis of rotation of the wrist, the extensor carpi ulnaris functions to extend and ulnar deviate the wrist. So to isolate this muscle with manual muscle testing, you would perform resisted wrist extension with a component of resisted ulnar deviation. The extensor digitorum communis has also its attachment on the lateral epicondyle of the humerus through a short tendon, and then continues down to cross the wrist and to insert into the phalanges of the second through the fifth digits. And you can see that as this tendon comes down, it splays out to attach on all of the phalanges, with the exception of the phalanges of the thumb. So with regards to the extensor digitorum communis, you can see that your manual muscle testing of this muscle would involve resisted wrist extension combined with resisted finger extension. And again, this muscle here, because it attaches on each of the fingers, is going to be involved in those activities that involve repetitious finger movements, especially repetitious finger extension. And again, this is a two-joint muscle operating at both the elbow and down below at the wrist. And then finally, we have the extensor carpi radialis longus. Has its origin up here on the lateral supracondylar ridge. Supracondylar ridge is right above the epicondyle of the humerus. And this muscle extends down to attach at the base of the second metacarpal. So the extensor carpi radialis brevis attached on the base of the third metacarpal, the extensor carpi ulnaris attached on the base of the fifth metacarpal. So those three bones you can see are wrist extensor muscles. And then the extensor digitorum communis, by its attachment on to not the metacarpals, but onto the phalanges, also involves the action of resisted finger extension. So with the extensor carpi radialis longus, your manual muscle testing is going to involve resisted wrist extension with a component of resisted radial deviation. Pain with resisted wrist extension and resisted radial deviation would strongly point to either the extensor carpi radialis longus or brevis as the tissue responsible for the production of the pain. So some epidemiology related to lateral epicondylitis. You're going to see that men and women are equally affected in the prevalence with which they present with lateral epicondyle pain. And typically the pain in this condition occurs in the 4th or 5th decade of life. So we're looking at examinees somewhere between the ages of 30 and 50, with symptoms being more prominent in the arm most repetitiously used, which is commonly in the dominant arm. And these examinees are going to present with a history of manual labor, typically involving heavy tools. By heavy tools, we mean greater than 1 kilogram, which is 2.2 pounds, and significant strain while reporting and performing repetitive tasks. And this lateral elbow pain is going to go through a continuum of pain presentation. And if you recall, in session 1 of this program, we talked about the continuum of cumulative trauma pain, with the first level of cumulative trauma pain being pain after the performance of a specific activity. So, for example, if you have an examinee who's involved with using a hammer to pound nails, he may report to you that he has pain after hammering nails. Well, as this condition progresses, the pain will progress to pain that not only is present after the performance of hammering nails, but pain that is present with the beginning of hammering nails, but that resolves with warming up of hammering nails. Okay, so we progress from no pain while hammering nails to pain after hammering nails, to a condition where the pain is present at the beginning of hammering nails, but that resolves with warm up of hammering nails, to finally pain that is constantly present in the elbow, regardless of hammering nails or not. So this is the spectrum across which you're going to see examinees presenting with elbow pain. Simply pain that's activity related in the early stages, and then in the end stages with chronic degenerative changes of the tendon, the pain is going to be constant, and it's going to become a stubborn condition as described in the AMA guides. And as you're going to see, it's going to become recalcitrant recovery. And these are the type of examinees that go on to require a permanent impairment rating. Now, this program is about lateral epicondylitis in the industrial setting. It's not about athletic lateral epicondylitis, but I think some understanding of this condition as it commonly occurs in tennis players gives us some insight into some of the factors that contribute to the development of lateral epicondylitis in the industrial setting. So I don't know if you have Tennis Channel or not. I have Tennis Channel, and I find myself watching a lot of tennis, and I'm constantly amazed at the stories of the number of tennis players who have had multiple elbow surgeries over the courses of their career for the attempted resolution of chronic and stubborn lateral epicondylitis. I can name several tennis players right off the top of my head who have undergone single or multiple procedures because of this persistent problem. So with tennis players, like industrial athletes, poor technique contributes to the development and the persistence of lateral epicondylitis. Improper racket or improper racket grip size can contribute to lateral epicondylitis, and this is going to be a common theme in the industrial setting, where poorly fitted tools and mismatched tools can contribute to the development of lateral epicondylitis. Excessive playing time, where the tendon takes some use and abuse during playing time and practice time, and there's insufficient recovery time to allow healing and regeneration and recovery of the tendon, sets the stage for chronic degenerative changes of the tendon due to an imbalance between use and recovery. And then in addition, we see that in those players that use a two-handed backhand stroke, those players develop lateral epicondylitis with a much greater and a much reduced prevalence than do tennis players that have a one-handed backhand stroke. And as we're going to see in the industrial setting, one-handed use of tools, especially through the use of the dominant hand over and over and over again, contributes to this condition in the industrial setting. So there's some interesting parallels between lateral epicondylitis in tennis players and other athletes, and with our industrial athletes in the workers' compensation setting as well. Now, in an examinee who presents with lateral elbow pain, you're going to have several differential diagnoses. Those include cervical radiculopathy, fracture of the radial head or the radial neck, osteoarthritis, lateral elbow instability is one of the differentials, and then compression of the posterior interosseous nerve can also cause lateral elbow pain. Well, with cervical radiculopathy, the examinee is going to report numbness and tingling in the arm and hand, and also in the fingers in the distribution of the specific dermatome. Typically with lateral elbow pain, we're talking about the C6 dermatome. On physical exam, this examinee will have a positive Sperling's test. They'll have diminished reflexes, specifically of the C6 nerve root, which is the extensor digitorum reflex or the brachioradialis reflex. And then they'll also complain of night pain that is unrelated to activity. And that's a strong differential between radiculopathy and lateral epicondylitis, is that lateral epicondylitis is associated with pain after activity, whereas cervical radiculopathy is unrelated to activity. With radial head or radial neck fracture, the examinee will have a history of trauma. Typically, that involves a fall on an outstretched hand that jams the radial head up into the capitellum of the humerus bone. And on physical exam, there'll be swelling, there'll be crepitus, and there'll be a block, a hard block to motion, that is painful. With osteoarthritis, there'll be a history of remote trauma to the elbow, perhaps involving a prior surgery that has left the examinee with some deformity or stiffness. And they may have some history of other systemic arthropathies such as gout, such as psoriatic arthritis, or such as rheumatoid arthritis. With elbow instability, the examinee will have a history of a prior dislocation, perhaps corrected by a prior surgical procedure. With elbow instability, the examinee will report a feeling of weakness and a feeling that the elbow is going to give way under load. On physical exam, especially with medial and lateral elbow stress testing, the examinee will demonstrate the apprehension sign with stress of the elbow as the examinee fears pending redislocation or possibly subluxation of the elbow. And there'll be crepitus on joint movement as that joint tracks poorly throughout the range of motion. With compression of the posterior interosseous nerve, which is a branch of the radial nerve, there will be weakness of the thumb and finger extensors. There may be a complaint of numbness and tingling on the dorsum of the wrist along the dorsum of the radial bone and the top of the thumb. And this is a type of examinee who may have had some compression of the posterior interosseous nerve down by the wrist, perhaps due to too tight fitting gloves, or perhaps due to some sort of straps that go around the wrist that have compressed the nerve down at the wrist. So of these differential diagnoses, cervical radiculopathy is going to be the one that you'll most commonly encounter. So let's talk about the role of cervical radiculopathy in the production of lateral elbow pain. So with lateral elbow pain and lateral forearm pain, we're going to most commonly associate pain in this region with radiculopathy of the C6 nerve root. C6 nerve root innervates all of the wrist extensors and is going to affect the brachioradialis reflex. So the examinee will report symptoms in the lateral forearm and hand. They'll have weakness to resisted wrist extension, and they'll have some diminution in the brachioradialis reflex. With a C7 radiculopathy, we're going to see involvement of the extensor digitorum communis, which is going to affect resisted finger extension. So there'll be weakness to resisted finger extension, and there'll be some diminution in the triceps reflex. So lateral elbow pain can be confused. Lateral epicondylitis can be confused with radiculopathy of either the C6 or the C7 nerve roots because they have overlapping weaknesses and overlapping distributions of pain. And this diagram from Chapter 15 of the AMA guides shows the distribution, at least of the dermatomes of the cervical spinal nerve roots. So this is the region of pain wherein the examinee will report pain with lateral epicondylitis, and you can see that that is similar to the distribution of pain that would be reported with a C6 radiculopathy. And with C6 radiculopathy, the examinee could also report pain into the hand, could report pain and weakness on resisted wrist extension with resisted radial deviation as well. And then for C7, the pain is going to be into the middle finger, which is where we know the extensor digitorum communis also attaches. So the examinee with C7 radiculopathy will also have weakness to resisted finger extension, especially of the middle finger. So cervical radiculopathy can be commonly confused with lateral epicondylitis. So let's talk about some of the physical examination findings here in just a minute that are specific to lateral epicondylitis that will distinguish it clearly from cervical radiculopathy. But before we do that, let's talk about some of the specific causes and specific types of repetitive motions that are associated with the development of this condition. Well, here's what a recent 2013 study published in the American Journal of Industrial Medicine concluded were work-related risk factors for lateral epicondylitis and other nonspecific causes of elbow pain in the working population. And so in this study, they compared employees who had definite diagnosis of lateral epicondylitis compared to other employees who had general and nonspecific elbow pain not associated with lateral epicondylitis. And what they found was that lateral epicondylitis as a specific condition, lateral epicondylitis was strongly associated with specific elbow movements. Well, let me ask you, what type of elbow movements do you think would be strongly associated with lateral epicondylitis? Well, it's found because the forearm extensor and finger extensor muscles are two joint muscles, that the specific elbow movements most strongly associated with lateral epicondylitis involve resisted elbow extension, especially in a resisted eccentric muscle action. A resisted lengthening contraction of the elbow and finger extensors is strongly associated with lateral epicondylitis. Also, combined elbow flexion and extension combined with actions at the wrist, including wrist flexion and wrist extension. And again, because these are two joint muscles, they're affected by actions at both the wrist and the elbow. So imagine the elbow in full elbow extension and the wrist in full wrist flexion. That places these extensor muscles at their maximum length. Well, at the maximum length under load, meaning under repetitious contraction, this is the type of repetitive movement that's going to cause some reactive changes in the tendon high at the elbow. In addition, it was found that employees who perceived their job duties to involve great physical exertion, they seem to report lateral epicondylitis symptoms more often and with greater severity than employees who had the same job duties but who perceived the physical exertion demands of their job to be lesser than those who complained of lateral elbow pain. So it seems that the presentation of lateral epicondylitis has a great deal to do with how physically demanding the employee perceives their job duties to be. Also, the use of heavy tools greater than 2.2 pounds, especially in the dominant upper extremity, is associated with lateral epicondylitis. Forceful lifting greater than 44 pounds, which is 20 kilograms, at least 10 times per day. And I'm thinking of those guys that deliver the 5-gallon jugs of water. 5-gallon jugs of water are 40 pounds plus the bottle. So I don't know how many hundreds of those jugs of bottle those water delivery guys handle per day, but it's this type of repetitious forceful lifting that's associated with lateral epicondylitis. Also, repetitive movements more than 2 hours per day seems to be about the minimum threshold, 2 hours per day, to overwhelm the tendon and cause an upset in tendon homeostasis and create an imbalance between the rate of usage of the tendon and the rate at which the tendon can recover to baseline. And so failure to recover to baseline daily sets the stage for chronic and cumulative degenerative changes within the tendon. They found that the risk of suffering from epicondylitis increased significantly with age, and that sets the stage for some concern that lateral epicondylitis may be a normal age-related degenerative change of the tendon, thereby reinforcing the idea of an aging effect associated with tissue degeneration. And you probably know this from your clinical practice where patients coming into your office greater than 50 and into their 60s and 70s complain of all manner and all form of tendinopathies, especially up in the shoulder. And as we talked about in our last discussion, shoulder tendinopathy, again, is also associated with increasing age. Also, they found a strong association with a history of epicondylitis, seeming to suggest that these symptoms can recur over and over and over again. And as I said in the beginning of this program, on a personal basis, my own history involves cycling in and out of lateral epicondylitis due to a combination of physical activities as a chiropractor and also due to recreational weightlifting, seems to cause these symptoms to basically be right on the edge of occurring at any given point in time. And then some activity invariably comes along to upset the homeostasis of that tendon. And boom, I find myself back into active symptomatic lateral epicondylitis several times throughout the course of any given year. In this study, as we said, the perceived physical exertion was higher for workers with lateral epicondylitis than for workers with general, non-specific elbow pain not associated with lateral epicondylitis. The physical force exerted at work is objectively higher for workers with lateral epicondylitis than with elbow pain only. And general elbow pain they found occurred at a younger age than lateral epicondylitis. So again, reinforcing the idea that lateral epicondylitis involves some age-related degeneration of the common extensor tendon. Now, lateral epicondylitis is going to have some specific physical examination findings, typically involving tenderness to palpation greatest over the extensor carpi radialis brevis tendon, which is 1 to 2 centimeters anterior and distal to the lateral epicondyle. So why don't you go ahead and reach your finger over to your lateral epicondyle, move your finger 2 centimeters anterior and then 2 centimeters distal, and feel right into that soft connective tissue in there, and that's the tendon of the extensor carpi radialis brevis. Now, in a case of bona fide lateral epicondylitis, you should be able to produce a jump sign to moderate palpation pressure over the extensor carpi radialis brevis. A positive jump sign is the true positive objective finding to your palpation exam. Simply a report of pain or tenderness over the tendon area is not a true positive objective finding, but a jump sign constitutes the true positive objective finding. The range of motion of the affected side may be decreased. And remember, with the elbow, we test 4 ranges of motion. We test elbow flexion, elbow extension, elbow pronation, and elbow supination. And according to the AMA guides, 140 degrees is normal elbow flexion, 0 degrees is normal elbow extension, and sometimes in a hot case of lateral epicondylitis, the examinee may have an extension lag where they fail to be able to go into full elbow extension. And then 80 degrees are the normal ranges of motion for pronation and supination. With manual muscle testing, you're going to find pain and weakness to resisted active wrist or finger extension. And remember, you test resisted wrist and resisted finger extension with the elbow in full extension to bring all of these extensor muscles into active insufficiency. With the elbow flexed, we have a situation where we're dealing with the muscles in passive insufficiency, and because these are 2 joint muscles, we want to test the integrity of the tendon at the elbow joint, and so to do that we have to bring the elbow into full extension. We may see that because of the co-contraction of the wrist extensors with grip strength testing, we may see that the examinee has decreased grip strength. And then by orthopedic examination, we're going to see positive Cosen's and positive Mills tests, which are basically just various forms of resisted wrist extension testing involving either radial or ulnar deviation. So when it comes to providing for permanent impairment for these examinees, one of the impairments to consider has to do with abnormal motion. So if there's any loss of range of motion of the affected side, that would qualify for a permanent impairment rating due to abnormal motion. So let's take a look at those charts. So here in Chapter 16 of the AMA guides is figure 1634, which gives us our impairments due to abnormal flexion and abnormal extension of the elbow joint. So here is the pie chart. It gives us our flexion and our extension impairments. And you can see that the AMA guides consider 140 degrees of elbow flexion to be full and normal elbow flexion. So for that, they provide for 0% impairment rating. And then similarly, the AMA guides consider 0 degrees of elbow extension to be normal elbow extension. And for that, they provide a rating of 0% whole person impairment. Similarly, for pronation and supination, we have figure 1637. When we have 80 degrees of supination, that is a 0% impairment rating. When we have 80 degrees of elbow pronation, that is a 0% impairment. But for less than 80 degrees of pronation and supination, we get various impairment ratings here and here along the pie chart. So you can see that the impairment ratings are generally small, but they're definite. So always consider that your examinee may qualify for permanent impairment due to abnormal elbow motion. In addition to abnormal elbow motion, lateral epicondylitis can also qualify for permanent impairment due to its impact on grip strength. So in an examinee who has less than normal grip strength, you can provide for permanent impairment for that loss of grip strength. And in the AMA guides, table 1631 gives us some strength gradings for various different types of occupations. Now, most of these examinees are going to be in the manual occupations because of the repetitive elbow and wrist movements involved in the manual occupations. So we have the major and minor average grip strength for males, the major and minor average grip strength for females, and then all we have to do is determine the strength loss index, and we can come up with an permanent impairment rating due to loss of grip strength. Table 1632 of the AMA guides gives us various strength grades based on age in both men and women for both the major and minor hand. So with your examinee, you want to calculate any strength loss index that may be present both by occupation and also by age, and then provide for permanent impairment rating based upon the scale that gives the greatest or the highest permanent impairment rating. Now, I recently reviewed a case that involved loss of grip strength for an examinee who was greater than 59 years of age. And there was some discussion that the charts and tables did not apply in examinees greater than 60 years of age. So you can see here that the grip strength grade is dropping approximately 10% in the last 2 decades between 40 and 49 and 50 and 59. So you could project from this that some loss of strength in the 60 to 69 age range would be considered a result of normal aging. And I would say perhaps a strength grade loss of about 10% over these values could be considered within normal limits in the 60 to 69 year age range. So once you have your grip strength values in both the dominant and non-dominant upper extremity, in both the involved and the uninvolved upper extremity, then all you have to simply do is calculate the strength loss index by taking the normal strength value from the charts, subtracting the limited strength that's provided to you by your examinee, and dividing that by the normal strength again, as it's described in the tables in the AMA guides, to come up with a strength loss index. And then the AMA guides are going to provide for increasing impairment for increasing loss of strength. Another way to rate impairment for lateral epicondylitis has to do with loss of strength to resisted manual muscle testing of 4 motions around the elbow joint. So to resisted manual muscle testing, we're going to test resisted flexion, resisted extension, resisted pronation, and resisted supination. And if the examinee comes up with some loss of strength due to lateral epicondylitis, you can provide for permanent impairment due to loss of strength. So for a 25% loss of strength in elbow flexion, that qualifies for 5% upper extremity impairment. Same for extension. For pronation and supination, both of those qualify for 4%. So remember that that's upper extremity impairment. That would have to be converted into whole person impairment later on. So these values are small, but they're definite, and it's worth going through this analysis for those examinees who truly do have loss of strength of the elbow. For greater losses of strength, as much as 30 or 50%, as you can see here, the impairment values are higher. Now, similarly, this table, table 1635, does not describe loss of strength at the wrist. So what can we do? Well, if you believe it appropriate, you can use this table, table 1635, to provide for a permanent impairment rating due to loss of strength at the wrist. So at the wrist, the manual muscle test that we would employ would involve resisted wrist flexion, resisted wrist extension, resisted wrist radial deviation, and resisted wrist ulnar deviation. And you can analogize the unlisted condition, which is loss of strength of the wrist. See, loss of strength of the wrist is not a listed condition in this table. Only the shoulder and the elbow is listed. But you can analogize the unlisted condition with another listed condition, which is listed here as loss of strength of the elbow. So if you believe it appropriate and you can provide a good how and why reasoning, you can analogize this table to your findings for loss of strength at the wrist, thus giving you another opportunity to provide for permanent impairments due to lateral epicondylitis. And you may ask, can this table be used to provide for permanent impairment due to loss of strength at both the elbow and the wrist? And I would argue that that you can, as long as you have a good how and why reasoning, and as long as you have the physical examination findings to document loss of strength at the elbow and loss of strength at the wrist. I believe that this table can be used to provide for impairment due to both losses. Well, what else? Are there any other impairments that we have the opportunity or the option to employ in those cases that involve lateral epicondylitis? Well, if we take a look at the activities of daily living described in Chapter 1 of the AMA guides, they go into great detail about the importance of non-specialized hand activities in daily life. So non-specialized hand activities involve grasping, involve lifting, involve tactile discrimination, and any other non-specialized hand activity that you can think of, you can describe and you can provide for permanent impairment for an examinee who has true limitations with those hand activities. So as an example, with regards to lifting activities, the AMA guides describe here the function and the role of the hands in lifting activities. Well, in examinees with lateral epicondylitis, they're going to be limited in their lifting activities because of their hands, because of weakness of the hands, because of weakness at the wrist, because of the cause of the weakness, which is due to lateral epicondylitis. So we know that because these muscles are two joint muscles, they involve actions at both the elbow and the wrist and the hand. And as we saw, each one of the four muscles involved with lateral epicondylitis attaches down into the hand. So lateral epicondylitis can affect functions and activities of the hand. Well, if you have an examinee who has a bona fide and documented loss of capacity for lifting due to problems with his hands, you can provide for permanent impairment due to loss of lifting capacity. And we talked about this with regards to the shoulder. The shoulder is also involved with lifting, and any loss of lifting capacity due to shoulder tendinopathy qualifies for permanent impairment. Well, same analogy applies to loss of lifting capacity due to lateral epicondylitis and problems at the elbow. So in these cases, you can provide for a much higher permanent impairment rating than can ever be provided for by permanent impairment due to loss of range of motion and permanent impairment due to loss of strength in resisted elbow and wrist movements, as we just saw in our previous slides. So let's say you have an examinee who regularly lifts 40-pound water jugs more than 20 times in any given day. Let's say you have an examinee that works for Alhambra Water, and he delivers those 40-pound jugs. Well, if you have documented work restrictions limiting that particular examinee to, let's say, for example, no lifting greater than 5 pounds or no lifting greater than 10 pounds, that represents a significant loss of lifting capacity due to lateral epicondylitis. If that's true, if that's documented, and if the examinee has a bona fide loss of lifting capacity, you can analogize to Chapter 6 hernia and provide for a Class 2 impairment due to frequent elbow discomfort, which precludes heavy lifting but does not hamper some activities of daily living. And this allows for 10 to 19% impairment of the whole person. And you can use your clinical judgment in coming up with an impairment rating between 10 and 19%. If you have an examinee, and I recently had an examinee who regularly lifted up to 100 pounds in his job at the receiving dock at Walmart. This is a guy that dealt with pallets and boxes and awkward and cumbersome items out there on the receiving dock at Walmart, and he was involved in regularly lifting up to 100 pounds. Well, his most recent medically prescribed work restrictions involved no lifting greater than 5 pounds, a significant loss of lifting capacity for an otherwise healthy, 35-year-old, 6 foot, 220-pound, healthy, strong male. So that might be the type of case that qualifies for the higher permanent impairment rating within the range. And in this way, the loss of lifting capacity is the more accurate description of the permanent impairment that can ever be provided for by, for example, loss of range of motion. In fact, this particular examinee at Walmart, he had normal range of motion of the elbow. He did not have loss of flexion. He did not have loss of extension or pronation or supination, but he had significant loss of lifting capacity. And so this was the most accurate description of his impairment under Almarez and Guzman by analogy to Chapter 16 hernia. So you always have this option in those cases where lateral epicondylitis affects the examinee's lifting capacity.
So doctors, I hope this helps you. With lateral epicondylitis, this is a condition that is the result of repetitive and cumulative trauma. And in the absence of workplace modifications, this is the type of condition that becomes chronic and will never get well because the tendon undergoes degenerative changes. We talked about those degenerative changes, tendon disrepair and degenerative tendinopathy in prior sessions. And when the tendon undergoes degenerative changes, it likely will never return to pre-injury condition because of those degenerative, irreversible and degenerative changes. So it's important that you provide a permanent impairment rating that's a true reflection of the examinee's true condition. And many times the true impairment rating is not provided for under the strict application of the AMA guides. As we saw by looking at the figures and tables in the AMA guides, permanent impairment ratings due to loss of range of motion and due to loss of strength and even due to loss of grip strength are generally small. So in these cases where these small impairment ratings do not seem to accurately reflect the true impact of this condition on the examinee's work and daily living activities, you might opt for an alternative impairment rating under Almarez and Guzman, and you always have the option to employ the loss of lifting capacity analogy under Chapter 6 in those cases where examinees have a bona fide and a documented loss of lifting capacity. So this is a way that you can provide a true and accurate description of their permanent impairment rating. So I hope this helps you. I tried to present in this program a couple of different perspectives for you under the strict application of the AMA guides, and then also a couple of perspectives under the Almarez Guzman interpretations as well. So in our next session, we're going to go into permanent impairment ratings of some lower extremity tendinopathies, and I have a fascinating discussion for you on patellar tendinopathy, Achilles tendinopathy, and also plantar fasciitis, which is a form of tendinopathy, and I want to share with you some actual case examples where examinees have received generous permanent impairment ratings for these lower extremity tendinopathies. So for today, this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on this video. Look forward to being with you on our very next session as we continue in our ongoing program entitled Permanent Impairments of the Tendinopathies. For now, I'm wishing you best of success in your career as a qualified medical evaluator.